It is my privilege and pleasure to talk to you on behalf of UT Southwestern and the Department of Urology and all involved constituents on our campus about a new initiative, the Prostate Cancer Program. My name is Roehrborn. I'm professor and chair of the Department of Urology at UT Southwestern here in Dallas. Oftentimes in life we are faced with difficult decisions, and it looks like this maze, and sometimes more often or less often, we find ourselves in need of help to figure out a way through this maze or around the maze, as the case may be. This is probably more common in medical decision-making than in many other parts of life. Medical decision-making can be some of the most complex that we have to deal with in our life, and also the decisions are of great consequence. The diagnostic algorithms that physicians usually apply and the therapeutic choices can be confusing in their complexity. And honestly, large healthcare systems such as ours, much as they try, are often difficult to navigate. You're all familiar with calling a number and hearing a recording and picking a number to choose, leaving a message, etc. So, particularly when you have cancer, such situations and difficulties can be agonizing and induce quite a bit of fear. And talking about cancer, and specifically prostate cancer, there's 2 million new cancer cases and 618,000 cancer deaths per year in the United States in the year 2025, based on the American Cancer Society data. That's 4 new cases per minute and 1 cancer-related death per minute. And if you translate that, by the way, to prostate cancer, which we're talking about here, that's 1 new case of prostate cancer every 100 seconds, so a bit more than a minute and a half. This shows the 2025 data, the estimated new cancer cases and estimated cancer deaths on the right-hand side for both sexes, for all cancer types. And you can see on the left-hand side that breast and prostate cancer are clearly dominant. Breast is just 5,000 cases more, but prostate cancer and breast cancer are above 300,000. No other cancer is. If you look at death, it's a different story. Lung and bronchial cancer occurs both in men and women, and therefore it has also a higher mortality. 124,000 people die from it every year. But breast alone is 24,600. Prostate alone is nearly 36,000. So it's actually relatively similar between prostate and breast cancer when you look at the mortality. And certainly when you look at the incidence numbers, it is a very similar and by far the most common man if you look at sex specific. Now, when we look at male only, clearly that changes the playing field, because then prostate cancer becomes the dominant cancer, and with the 35,000 death related to prostate cancer on the right-hand side, still follows second after lung cancer, but trumps colorectal cancer and pancreatic cancer, etc. So it's clearly a big problem for the male population in this country as in most other countries. How about in the state of Texas? Well, in the state of Texas, prostate cancer makes up 21,000 cases compared to 24,000 breast cancer cases. And when you look at the deaths due to cancer, it makes up 2,470, as you see on the right-hand side. These are data 2025 specific to Texas based on American Cancer Society data. Now, who gets this cancer by age and who dies from the cancer by age? That's very interesting. If you look on the left-hand side, which shows prostate, breast, lung, and bronchial cancer and colorectal cancer, there is no other cancer where age plays such a big role. Whether you are under 50, 50 to 65, or 65 and older, plays a big role. The older, the more likely it is you get prostate cancer. The younger men don't get prostate cancer as often. Look at breast, for example. Breast cancer is also less common in the younger, but it's a huge difference in the age sticks, if you will, on this bar graph, horizontal bar graph, for breast and for prostate cancer, where it's more spread out. On the right-hand side, you can see that for prostate cancer, a death due to prostate cancer in the younger groups is virtually unknown, but it's affecting always the older or elderly 65 and older, as you can see on this graph. Why do I say that? Why is that important? Well, it's pretty important if you look at the aging of the population. Look at this population estimate and population prediction, and look at the line graphs for 65 and older and 25 to 64. Those dashed lines go up and up and up. Why is that? It's the aging of our population, where more and more people get to an advanced age. Why is that again? Because we successfully combated other diseases, cardiovascular diseases, healthier lifestyles, etc. People just simply get older, and as they get older, they're more prone to prostate cancer, as I showed you a moment ago. Now, here at UT Southwestern, in the last 10 years or so, we experienced an increase of 223% in the number of analytical prostate cancer cases, from 448 to 1,448. But we know that's not all there is. If you look at Dallas County, Tarrant County, Denton County, and Collin County, at the statistics, you can see Denton County, 580 cases of prostate cancer, Collin County, 714, Tarrant County, 1288, Dallas County, 1348. So that's a total number of 4,500 or so prostate cancer cases in just those 4 counties, let alone the counties surrounding us, smaller counties, but adding to it. So our drawing area, the immediate drawing area, probably has 5,000 cases, and North Texas makes up quite a number of the total number that I mentioned for the state of Texas, of about 21,000 cases that are in our immediate drawing area. The Dallas-Fort Worth area specifically is one of the fastest growing areas, and it's predicted to increase from 3.5 million to 4.1 to 4.7 by 2040, and that's just the narrowest definition of the DFW area for the male population. That's only half of the total population. The total is already way above 7 million. I think it's more like 8 million right now, and by 2030 and 40 it will increase even more. So when we're looking at this maze analogy again and prostate cancer, that's what I want to guide you through right now a little bit, this diagnostic algorithm. How do we get to a diagnosis, and how do we make the diagnosis, and how do we get from the diagnosis to a meaningful treatment in prostate cancer? And these algorithms are as difficult as they to understand for patients sometimes, as important are they for us physicians, so that you as a patient come to a physician and you can expect an algorithmic, by the books, guideline-driven evaluation and diagnostic steps that are taken very systematically and in a very efficient and effective manner. So the algorithms help out in what the doctors do, only for the patient it can seem very complex. So how does prostate cancer get diagnosed? And well, it used to be the finger exam, and many of you may know this, they had it, and you may have feared it, or you think it's kind of annoying, obnoxious. Well, we did this for decades. We did the finger examination, put our finger on the backside of the prostate, as I show here, and hope to find cancer, even if the cancer is on the front side. Well, that's not terribly successful, I might say. And the question I asked, does this apple have a worm? Well, if you look at the apple from one side, you can't see the worm. If the cancer is on the other side, the finger cannot feel it, even if the cancer were somewhat nodular, even if the cancer would represent a hot spot in the prostate. You just couldn't really feel it from the backside. So does this apple have a worm? Well, the finger exam is not the best to tell. So how else can we find it? Well, we developed in the 1990s a technology by doing ultrasound through the rectum. A rectal probe was inserted, pushed against the rectal prostate, and then we used the needle to biopsy the prostate. We called it systematic. Other people called it random. Now, random could be the same as systematic. It's still random. We didn't know where the cancer was. We just stuck the needle in there 12 times or 15 times or 18 times in a systematic manner by a grid, if you will, and we were lucky if we found the cancer by this mechanism. This was not the best, but it was an improvement, because at least we did a systematic assessment of the prostate, to the chagrin of our patients who don't like these biopsies. We don't like them either, because they are an invasive test. Now, enter the PSA. The PSA came into the picture also around 1990. It was invented in Buffalo, New York, and it is a breakthrough event in the history of prostate diseases for men. The PSA is an enzyme made by the prostate, released into the circulation. We measure it in the bloodstream. I have patients always ask me, is that in the urine? No. Even though the prostate is closer to the urinary tract, the PSA is a blood test. It's measured in the serum, and it's an enzyme that is expressed and made by the prostate, released into the circulation. We measure only the part in the serum. So I have this traffic light analogy, and I recommend for everybody to remember this, because it's a really good analogy. If the PSA is under 2.5, your traffic light is green. You can drive through the intersection. You're good. If the PSA is 2.5 to 4, the light changes to orange. What do? You slow down, you look left, you look right, you gingerly and slowly move your way through the intersection. But you consider this. You consider repeat testing or further investigation. You're just aware something isn't quite right anymore. If the PSA is over 4, for the most part, that's a hard stop red. For most men who have it, that does require further investigation. So try to remember that. Under 2.5, 2.5 to 4, over 4. Traffic analogy, traffic light analogy. So the PSA helps us to decide when to do a biopsy, when the PSA is high. The ultrasound helps us to do the biopsy. The PSA tells us when to do a biopsy. Well, the U.S. Preventive Service Task Force is a governmental agency that rules basically on the utility of tests like mammography or colonoscopy or chest x-ray or lung cancer or CT scan for pancreatic cancer. And at some time point, the U.S. Preventive Service Task Force in 2012 said, we don't think PSA is all that good. We recommend you not doing it all that much. And now look at this line graph. After the U.S. Preventive Service Task Force basically said, we don't recommend it, the diagnostic rate of prostate cancer plummeted. And in 2008 and 2012, they released these statements. In 2018, something changed again, and they changed the recommendation and said, nope, we think PSA may be useful, so you can discuss it with your patient and may do it, and the diagnostic rate went up again. So go figure. These guidelines made by the federal government did have an impact. Many of us in urology don't quite understand what changed. The data didn't change, but the interpretation of the data changed. And the U.S. Preventive Service Task Force reinterpreted, uninterpreted, and then came back to the old baseline. So for a while, primary care doctors weren't pushing the PSA. And many of you may have asked yourself, why no PSAs is here? And the primary care doctor says, well, it's not recommended. Well, now it's recommended again. I wanted you to know, since 2018, with a discussion on the pros and cons. But you should ask the question, and you deserve to have that PSA blood test done. Now, instead of doing just the DRE, we draw the blood for the PSA, then we decide to do a biopsy. And the question is now, well, can we do any better than this TRUS? The systematic biopsy, the random biopsy, finding the needle in the haystack, the proverbial haystack. And yes, we can, but only for the last 10 years or so, because MRI grew up. MRI was good to find, kidneys, pancreas maybe, but not for the prostate. It's a small organ. So now with the multiparametric MRI, using a high-resolution 3 Tesla scanner, we can actually identify areas in the prostate. Yep, that looks suspicious for cancer. So there are examples here. That looks suspicious for cancer. That looks suspicious for cancer. On these different phases that we have. That's why it's called multiparametric. And then the radiologist can grade it by a pirate grading system. Pirate 1, 2, 3, 4, 5. And we're really interested in the higher grade, 3, 4, and 5, because they convey a higher risk of cancer. If I biopsy a patient with a pirate 5, it's a 90% chance of cancer. Pirate 4, it's like a 60% chance of cancer. Pirate 3, it's a 35% chance of cancer. Pirate 2 is basically par for the course. You might as well do a random or systematic biopsy. So MRI can tell us where's the spot, where should we do the biopsy. It changed again the algorithm, you see. Now, how do we do it? We'll do a fusion biopsy. What is that? I call it a direct image overlay biopsy. So how do we do it? We have the MRI. We know that's the spot. How do I biopsy it? The patient is not in the MRI scanner. So I take the MRI, I overlay the MRI with an ultrasound, 2 images. I overlay it and I make it match. And when it matches perfectly, that's why I call it direct image overlay, when it matches perfectly, not halfway, not partially, not so-so, but perfectly, then I biopsy that spot. That's a fusion, or direct image overlay biopsy. An incredible tool, super powerful, and it helps us to identify where the cancer is and then to biopsy that particular lesion inside the prostate. Change the algorithm forever. There's multiple papers. I don't bother you with data in this talk, but here's one paper from the very famous New England Journal of Medicine 2021, and it showed that if you use MRI fusion biopsy, you'll end up doing fewer biopsy because you know when to biopsy and when not to biopsy. Okay, you do fewer biopsies and you find the same number of clinically significant cancers, relevant cancer, aggressive cancer, cancer you want to find, but you find fewer harmless cancer, clinically insignificant cancer, and the likelihood that your biopsy comes out with a benign finding no cancer is dramatically reduced from 43 to 11%. And the total number of biopsy procedures is reduced. So what's not to like about it? The MRI allows us to see whether there's a lesion in the prostate, regardless of the PSA is 2.8 or 3.5 or 6 or 5. And if the MRI is negative, we don't have to do a biopsy in many cases. So we reduce the number of biopsies. In those men where we do a biopsy, we find more relevant cancer, but less nuisance cancer, the cancer that we could just watch and observe. This is just one of many studies, but it's the first study that showed it in a randomized controlled trial beautifully. What about the DRE that you all hate? I didn't like it. I didn't like to drop your trousers, lean over. It was not my fun part of the examination in the clinic. So somebody went along and identified 8 studies with 86,000 participants that were trials that used DRE to diagnose prostate cancer. And what did they find? They find that the DRE, the finger examination of the prostate, adds nothing to the diagnostic accuracy when you use also PSA. So the screening strategy using DRE and PSA combined was no better than PSA alone, and DRE was not even close to being as good as PSA. So DRE as a screening tool is similar with a lower clinical detection rate. The combination did not improve the screening efficacy, and therefore DRE can potentially be omitted from screening and early detection. Do I still use it? Yes, but in a very different way. If a patient comes in with a PSA of 20 or 30, I'm thinking, wow, that's a high PSA. The disease could already be locally advanced, and then I can feel whether the cancer goes to the pelvic sidewall, the seminal vesicle. I can feel that for sure. But I don't do it for a patient with a PSA of 4.5 or 5 or 6. I can't feel it. I'd much rather go the route of doing the DRE, doing the MRI and the fusion biopsy. So the algorithm now, which started out with the DRE, went to the PSA, changed. So the DRE is out the window, but instead we now do 2 PSAs. Why is that? Because like any other test in the book, the PSA can fluctuate. On Monday it's this, on Wednesday it's that. It changes a little bit. My patient always look at me, am I better? Is the cancer gone? No. The PSA just fluctuates, sometimes up, sometimes down. Don't go depressed if it goes from 4.5 to 4.8. No reason for depression. Also, if it goes from 4.5 to 3.9, the cancer is not cured. So it fluctuates. So the guidelines now says, you know what, if a man has an elevated PSA and you bank on that and you want to do a diagnostic test, repeat it, just verify it. Verification PSA is the number one step to assure we're looking at the right situation, we're looking at the situation correctly, and we're drawing the right conclusion. That's the guidelines. Those are guidelines from our professional organization, the AUA, and the Society of Urologic Oncology. Repeat, verify. Good. So 2 blood tests, PSA is high, you repeat and verify. Get the MRI. If there is a lesion, you'll do the MRI fusion, direct image overlay biopsy, and we are there. So as many patients come to me and say, well, is the cancer spread? What does the MRI say? And I said, well, the MRI doesn't suggest it's spread outside the prostate, but it could be in lymph nodes, it could be in your bones, it could be elsewhere. So now, 5 years or so ago, a beautiful new imaging study came about, better than MRI for this, better than CT scan for this, much better than ultrasound. It's called PET scanning. PET scanning, in this instance, utilizes a tracer that finds prostate cancer cells called PSMA, prostate-specific membrane antigen, and it makes it light up like a light bulb. So the PSMA scan for those people at risk for spread, it's a godsend because oftentimes you find, oh yeah, you have positive lymph nodes, and here's where the lymph nodes are, or here is where the cancer is, and we can treat this, or we can treat that, or we can do radiation here. And in some men, unfortunately, it may say, no, your cancer is beyond the prostate, beyond the pelvis, it's in your retroperitoneum, in your abdomen, in your liver, in your bones. We cannot cure it, we just have to palliate it. But we spare you unnecessary pelvic radiation, unnecessary surgery with all the complications. So it's always a good idea to have this test if you have a high-risk cancer. Not for every patient. Low-risk cancer and intermediate-risk cancer often don't need it. But if you have high risk, it's a wonderful tool to identify where the cancer is. Also, it helps us to find the cancer when it comes back after an initial seemingly successful treatment. Good, that's where we are. We do our PSA, we do our MRI, we do the biopsy, we make sure the cancer hasn't spread, and then we go and set out the treatment. But when we go to the treatment, a whole new algorithm starts, a whole new set of rules start. This is one sheet of like 25 sheets of the National Comprehensive Cancer Center Network Clinical Practice Guideline for Prostate Cancer. And you can see already how it gets complicated. If this happens, then you should do this. And then you stratify by age, by PSA, by number, of course, on and on and on. This is one of 25 algorithm sheets. And I don't expect that you would know that. I don't expect that primary care doctors know it. In fact, most urologists wouldn't know all the details because it's complicated. It depends on age and presentation, when to repeat it, when not to repeat it, 1 year repeat, 2 year repeat. Who can remember all this? It's a super complicated algorithm. So again, that's where you are. You are in this maze. What we want to be, we want the people in the prostate cancer program to help you find the easy way, not the hard way through this algorithm, through this maze, but the easy way. The prostate cancer program is an initiative on our campus which has both a space at regional sites as well as on the main campus for patients to come to see us, be assessed, even virtually. It will provide increased capacity for visits, for MRI imaging, for fusion biopsies, for PET scanning, and provider capacity. Everything I mentioned, because it's all important steps in this algorithm. The care will be multidisciplinary. Even if we're not in the same room with two doctors, we can make doctors visually appear on a screen and have a conference with two doctors. Let's say a urologist and a radiation oncologist, or a medical oncologist and a radiation oncologist discussing refinement of treatment for an advanced cancer. There will be resources, videos, online documentation, in-person or group education in conference settings, maybe with cookies and soft drinks, and have an evening meeting. Somebody will talk about diet and prostate cancer. And most importantly, we will have navigators, professionals, nurses, or APPs who will basically pick up a referral for an elevated PSA and immediately contact the patient. Okay, you need to verify your PSA, repeat it. You need an MRI. I set it up. Immediately. I mean, when I say immediately, I don't mean within a minute, but the same day make a contact, the next day repeat the PSA, within a week or two do an MRI. That would be a huge step forward. I'm sure you share this with me, that it's a huge step because it reduces the fear. So what it means for patient, it should be flexible, it should be convenient, either telehealth, virtually, or in a regional center, be it Las Colinas, be it Richardson, be it Frisco, be it Redwood, wherever we are and you live. We want to be convenient, rapidly accessible with increased providers, increased ability to do MRI scanning, increased biopsy facilities. We want to get everybody involved, not just primary care urologists, but medical oncologists, radiation oncologists, radiology. We want to offer clinical trials for all stages of cancer. And patients should be always enabled and have full access to all the knowledge. And the patient navigator will play a very, very specific part in this role, in this prostate cancer program that we are building here at UT Southwestern for you. I want to focus on one very specific aspect now. I want to ask the question and then answer it. Who actually gets the PSA? You think everybody gets the PSA or should get the PSA or could get the PSA, but who really gets it? Well, if you look at prostate-specific antigen testing for men 50 and older, for whom it is allowed or recommended by state. So we're in the middle category. Our green is not the brightest green and not the darkest green, so we are in the middle. But if you look on the right-hand side for Texas, there's something very interesting. Look at this. In the state of Texas, 85% of women get a pap smear. 87% in the United States. We are on par. The state of Texas is good. We are on par with the US average. But when it comes to mammography, wow, it's 64 versus 71. When it comes to colorectal screening, it's 61 versus 75. And when it comes to PSA testing, it's 28 in Texas, 44% in the US. What's going on in the state of Texas? Are we not smart enough? Are the doctors not convincing enough? They're not educated enough? The men don't want to have it? I don't know. But it does worry me that we are below the national average in men 50 years of older having a PSA test. Let's dig a little deeper. And again, these are wonderful data from the American Cancer Society on cancer statistics, asking the question, who gets a PSA? Now comes something that is sobering. It's a sore spot currently in American society, in politics, and I'm going to try to be above politics. I'm just telling you how it is. On the left-hand side, you can see that the likelihood of getting a PSA test is higher for a higher socioeconomic status, as is SES. So that's a socioeconomic status. There's a formula that's applied, and the higher it is, the higher is the likelihood of getting a PSA test. On the right-hand side, it compares educational status. College graduate, some college, high school, less than high school. The difference between no high school graduation and college graduate is 21 to 41. It's a doubling. So having that college degree makes men more educated. They ask for it. They speak up. They say to the doctor, look, can I have this PSA test done? No high school or barely high school puts that way down. Sad, but true, and kind of understandable. People don't speak up for themselves. Now comes the age. Clearly, there's something good here. The older people ask more for it, the 60 plus, compared to the 50 to 64. Makes sense, right? But if you're 55 and you have prostate cancer, your life expectancy is 30 plus years. So shouldn't you know? So I would say 50 to 64-year-old should be just as high and thinking about it. Just last week, I saw a patient who actually did go to his doctor. He was African American. He did go to his doctor. He had a PSA. It was 7. Doctor said, see a urologist. Patient said, yeah, I'm not sure. Next year it was 9. The doctor said, you should see a urologist. Patient said, I'm not sure. Next year he was 53. His PSA was 17. Doctor said, you must go. I saw him. And he has prostate cancer, and it's bad cancer. Very sad. You know, it's not just getting the PSA, also interpreting it. 2.5 or less, 2.5 to 4, 4 and above. Remember what I said about that. Now let's look on the right-hand side. Let's look at the race. White, black, American Indian, Hispanic. The highest rate of PSA testing by far is 38% for white, followed by blacks 31, Hispanics 28. Okay, so you say, well, that's just how it is. Maybe they speak up more, they're more demanding, they ask for it, or it's more offered. Who knows what all plays a role in that? But it's disturbing that the people who have more cancer get less often the PSA test. And the people who die more from prostate cancer get the PSA test less often. Why would I say that? Well, here's some very interesting data, again, from the Cancer Statistics Center. It's online. You can look at this tool yourself. It looks at, on the left side, at incidence, on the right side, at mortality, and it looks at all cancers, both sexes. What I want you to see is that the incidence of all cancers, all sexes, between American Indian, white, black, Hispanic, and all races is relatively similar. This here is all races combined. And the white and the black, the big groups, are not too different. What about the mortality? This is all races right here. White are in line, black are a little higher, and Hispanics are a little lower. Okay, that's all sex, both sexes. I think we only have 2 sexes at the current political climate, no more than 2. Both sexes and all types of cancers. Fast forward. We look only at prostate cancer. Only men, only prostate cancer. Huge difference. What do you see? Black, by far the highest incidence compared to all races and certainly compared to white. Just look at the comparison. On the right-hand side, mortality. Black, 37.2, all races 19, white 18. A twofold difference. What's going on? Black men die twice as often from prostate cancer and are nearly twice as commonly diagnosed with prostate cancer. But they don't show up for PSA testing. They don't show up for voluntary PSA testing as much. I showed you that. What does that lead to? That leads to them being diagnosed later. When they're being diagnosed later, the stage is advanced. When the stage is advanced, they're more likely to die from it. So the biggest delta between black and all races or whites is mortality from prostate cancer. And that's unique to prostate cancer. No other cancer has that big of a discrepancy. So now you may say, well, difficult for a moment, and it's also sobering, very uncomfortable what I share with you now. This is not from the American Cancer Society. This is from a website called GloboCan. This is basically a global cancer monitoring network. This shows the estimated number of cancer cases in 2020 in the world, all men age 55 and older. All men, not women. By far the common is prostate cancer. Second common is lung, colorectal, stomach cancer, liver cancer, bladder cancer. Good. All men 55 and older. Now we look at new cases, prostate cancer, all ages, by income. I'll replace that with socioeconomic status. Higher socioeconomic status, more likely to be diagnosed with prostate cancer. Upper to middle income, less likely. Lower income, less likely. Less access, less opportunity. I don't know. This is the world. This is Africa and Asia and the United States. This is the entire world. So high income, higher likelihood of being diagnosed. Now comes the sobering part. This is the estimated number of deaths due to prostate cancer. The higher income group knows what to do. They get tested early, get treated successfully, pursue the treatment. They don't die as often. Middle income and lower income dominates. Sad. Worldwide, these data show that if you're in a lower income, lower socioeconomic status, you're later diagnosed, you're more likely to die. If you have higher income, yes, you get diagnosed and treated, and it's successful, and you don't die from the disease. Good. Let's go from the world and shrink the world and go to Texas. No, let's not go to Texas. Let's go to Dallas. These are selected zip codes of the DFW area, of specifically Dallas. Now, on this slide, you see actually the zip codes divided by college education. So the darker the red, the more of the population have college education. The highest is like 65, 70%, which I'm sure is somewhere in the Highland Park area, etc. So what you should see is that when you look at Dallas, what we consider Dallas here, darker reds north of the Trinity River, lighter reds down here, less college education. Makes sense. When you look at median household income, the same. Darker red, higher income above the Trinity River, South Dallas, lower income level. When you look at the race distribution, the percent of people who are African American in those zip codes, a reversal. The higher percent of African Americans live in all the southern suburbs, the lower in the northern suburbs. Complete reversal. Good. Everything I showed you before should now come into precise, crystal clear view. If that is also, then the southern suburbs of Dallas with a lower college educated group of people, lesser socioeconomic status, higher rate of African Americans should be the people most deserving of outreach, PSA testing, because they are most likely to be diagnosed later and die from the cancer. Now this shows a map of the zip codes in Dallas and the percent of African American in those zip codes, and that is actually a zip code map for Dallas that you can look for any zip code in the United States. Look at this table here. You can see that there's a lot of areas and zip codes with more than 40% of the population being African American, but there's no zip code with a higher proportion than the zip code 75237. This is where I place the red arrow, zip code 75237. Where is 75237? It's a zip code in South Dallas through which 67 runs, and in the heart of that zip code is the Redbird area where there was a shopping center. The shopping center got demolished or replaced or repurposed, and in that shopping center now UT Southwestern has a place there and Parkland has a place there in that old shopping center. And so here is my final plea. The Prostate Cancer Program at UT Southwestern will make prostate cancer evaluation, diagnostics, and treatment more accessible and more efficient. Full stop. For everybody, everywhere, anytime, including the Redbird UT Southwestern Center, where we would like to also have a satellite clinic and part of our prostate cancer program, so that we in the prostate cancer program can lift you up and everybody else and help you cross that maze. Just get through that maze, get to the other side. From the first inkling of a suspicion to your PSA testing, to the MRI, to the biopsy, to the PET scan if you need it, to surgery, radiation therapy, hormonal therapy, whatever it is you need. Let us in the Prostate Cancer Program be the one to help you through that. That is our goal at the Prostate Cancer Program here at UT Southwestern. Not an easy task, not a small task, and I'm dedicated, many of my colleagues are dedicated. It will take a lot. It will take space in the regional clinics on the main campus, increase capacity, increase staffing for urology, radiation oncology, medical oncology, surgical pathology, radiology, patient navigators to help you and everybody else through this maze, but also social worker, dietitian, chaplain, therapist. People are nervous, they get depressed, they need help. People ask about diet, what can I do? It will take this navigation. It will need new equipment, more MRI scanner, fusion biopsy system, more surgical capacity, educational programs. I mentioned that both online and in person, support groups, webinars, just like what I do here to inform you about this prostate cancer programs. What you can do is you can also help this program. You can support this program. We do need MRI scanners at a tune of $3.5 million per scanner. We need renovation and remodeling and new clinical space. We need patient navigators and other support staff. We need new fusion systems both on the main campus and in the satellite. We need to create these educational visits and videos, and we create an educational environment with webinars and with in-person meetings. We need to get more doctors, urologists, radiation oncologists, medical oncologists, radiologists, etc. And we want to have a program for the underprivileged, for those who are at risk to be diagnosed later and die more frequently in the southern suburbs. We are well suited. We have satellite clinics. We have them in Frisco, in Las Colinas, in Richardson, in Coppell, and in Redbird, in the heart of South Dallas, in the zip code with the highest African population. It behooves us, I feel we are called upon morally to help in that area and make our outreach and our improved access noticeably and palpable there as well in this prostate cancer program. It's a pleasure and a privilege again to talk about this program. I'm excited. This program is just in its infancy, but I believe when this year comes to a close, we will have it successfully established. It will be in place, and we will have a noticeable shortening of the time from first contact to the final evaluation and to the treatment discussion. I thank you for the attention you paid. If you care to, this QR code on this slide, you can probably hold your cell phone on it and it may read my name into your cell phone so that you'll have it available. And with that, I'll thank you very much again, and I'll leave this slide on for just a moment longer in case you want to try to use the cell phone for this purpose.